Okay, good morning, everyone. I was asked to speak with you about precision and personalized medicine in oncology, but in order to do so, and I'm speaking from the clinician view, but in order to do it, we need to get some perspective first in order to understand where we are coming from and where we are going to. And this slide might show you chronically that until the beginning of the millennium, we mainly gave chemotherapy in oncology. And only in the beginning of this millennium, we started biological treatments and targeted approaches. And I believe that we're heading to the more to the individualized medicine. I will try to explain what's the difference between precision and individualized, and you will see it during the presentation. So this is a pivotal study from the chemotherapy era, and you can see here a study where the researchers asked the question whether adjuvant treatment for breast cancer patients with chemotherapy might help. It started in the mid-70s, and you can see here the results of the publication 20 years later, and you can see two curves. One is the upper one is the curve that the patient received the treatment, and the down one is the one that the controls arm, where the patient didn't receive anything after surgery, and you can see a difference. And this difference is significant, is statistically significant, which means that we might use it as our own practice. But you can look on this curve in another way, and this is the fact that you can look on the patients, or at least on the areas of the patients, that they didn't really benefit from this treatment. And the meaning is that there are patients that will get the treatment and the disease will progress, or there are patients that won't get the treatment and they will never, and the disease will never progress. And if you see, at least, I won't show you exactly the numbers, but you can realize that there is around 90% of the patients that don't really benefit from the treatment, and in the other hand, they will suffer from the toxicity of the treatment. And that's actually what we are doing every morning when we come to our office and see the patients. We are telling them, listen, this is the situation, the treatment that we propose is this, the chances that it will help you is 10%, 20%, and that's what I recommend you. And this is actually the reality that we are living in. And I've shown you a very early study, but you can see it also in the new studies with immunotherapy. I don't know if you know this study for melanoma patients that compare between one kind of immune checkpoint versus another one versus a combination, and you can see that the combination, the patient that received the combination treatment did the best, but still 50% of the patients don't do good. The disease is progressing, which means again that even with the new drugs, we are still using the empirical approach. And the meaning of this approach is that usually what we will do, we'll take a patient, take the anamnesia, and then we will decide which treatment to give him based on empirical data. And we will try it on him. We will wait for 2 or 3 months. We see if he responds or don't respond. And then if he don't respond, we will go to the next line of treatment. And we will do it, as a way of trial and error. And that's the way that we are treating cancer patients in general. And so on the 70s, a huge amount of money started to move to cancer research, and immediately there were some very interesting results, and you can see some of them here on the board. In the beginning of the 80s, Bob Weinberg identified the first oncogene, human oncogene, and then in 1986 the first tumor suppressor gene, and we started to understand more and more the biology of cancer, which led to developing of new drugs that targeting the specific mechanisms. And you can see here some of the new drugs that entered our practice during the last 20 years. You can see here HER2 in breast cancer patient, which is targeted by trastuzumab or pertuzumab. There are colon cancer with KRAS mutations that won't be treated with EGFR antibodies, the lung cancer stories that I will speak a little bit now, and some other interesting new treatments for specific diseases. And here are some of the examples. In the right, you can see the melanoma cohorts patients that are receiving with BRAF mutations that receive BRAF inhibitor. You can see in the left side a curve for patients with specific very rare sarcoma called GIST that receiving Glivec. And we have, of course, more and more these kind of examples. And the lung cancer story is I will detail it now in the next slides. So in the beginning, like 17 years ago, this study was published in the New England, showing the reality for lung cancer patients, where we give them different chemotherapies duplicates, and you can see two things here on this slide. One, there is no difference between the duplicates. The other thing, that it doesn't really work for the patient. You don't see in the slide, but I can tell you that these duplicates are very toxic. And then during these years, in the 2000 to 2005, we understood that EGFR might be an interesting player in lung cancer. And initially, the two drugs was designed for inhibiting this mechanism, and the patients was treated with it, but they didn't respond because the fact was that every patient with lung cancer was recruited to this kind of studies until in 2004, two studies from Boston revealed that it might work only on patients that have mutations in EGFR, activated mutation, and then new studies was designed, and more specifically for patients with EGFR mutations, and suddenly we started to see positive results for these patients. And then the next step was to understand why these patients eventually develop resistance, and you can see here that one of the main mutation that was developed for resistance for these drugs were EGFR T790M, and you can see on the right a curve of a later study with a specific drug, a second generation or third generation EGFR inhibitor that inhibits this specific mutation, and then the patient can actually get 2 lines of biological treatment that is a pretty benefit for them and definitely prolongs their lives. During the last 20 years, we started to use a new kind of technologies, the microarrays, the high throughput technologies, initially for identifying expression arrays and then next generation sequencing. And you can see here a slide trying to explain the new technology. And one of the most important part here is the fact that sequencing became more and more cheap, and then it actually led to our abilities to do a whole genome sequencing or panel of genomes of genes to identify in a tissue in one day in a pretty low cost for each test. And you can see the different mutations and DNA alteration we can identify through these technologies. And this slide shows that with the advance of the technologies, there is an evolution of molecular testing in different departments in the world. You can see here the lung adenocarcinoma, the lung department in Memorial Sloan Kettering, and you can see that initially in 2004 they was looking on 2 mutations, and now they are using panels of using the NGS technology to identify hundreds of mutations in each patient that enter the department. And this actually led to what you see here, to more and more identification of more and more subpopulation based on driver mutation for lung cancer. So initially, all the adenocarcinoma patients or the squamous and adenocarcinoma patients with lung that was originated from lung was the same disease, and we treated the same. Then in 2004, we divided them to EGFR mutated versus non-EGFR mutated patients, and now you can see that actually every patient is belong to one of the subpopulations, and there are more and more subpopulations, more and more variety of treatments for these patients with lung cancer. The same with breast cancer. 20 years ago, we already divided them to different patients based on the fact whether they had estrogen receptor or none, HER2 or none. Today, we are looking more and more on the genomic driver of these patients and trying to direct them to specific treatments, although the first line of treatment is usually the same like 10 and 15 years ago, but we have more and more clue how to treat these patients based on their drivers. And in prostate cancer, just recently, until recently we used the same drugs for all the patients. Now we are starting also to subpopulate them based on DDR gene mutations, and you can see that almost 30% of patients might get more specific treatment based on these mutations with PARP inhibitors, and hopefully we will have more and more subpopulation also in prostate cancer. And another thing that I need to show is this study in pancreatic cancer that was initiated in our institute by Talia Golan, where she has shown also that even the pancreatic cancer population might be divided to two. One is a very small one with a different DDR DNA damage genes mutations, and the rest are the rest. So how would me as a physician would approach the individual patient when he's coming to my office? So of course, initially, I will give him the standard of care treatments that we know to give. For example, a patient that developed urothelial carcinoma in the ureter. Initially, she underwent surgery and then adjuvant treatment, which didn't really help. And a year later, the disease relapsed in the retroperitoneum. She received a second-line treatment of chemotherapy, which of course is also very toxic, and she also get radiation. But again, the disease came back in the neck, and you can see here the disease. Then I didn't have any standard of care treatment to give her. It was 2013, and we started to send some of our patients their tissue to genomic analysis. So we sent her to genomic analysis, and it came back with this mutation, the FGFR3 249C, which we found out that it is an activated mutation. We didn't have any drug that would inhibit this mutation, but we heard that there is a phase 1 trial in Dana-Farber. She went to Dana-Farber. She started the phase 1 trial with FGFR inhibitor, and she did a complete response, and until today she is actually with no evidence of disease. But this is very rare case. Most of the cases, it's not this fairy tale story, okay? Most of the cases, when we send the patient for DNA analysis, usually there won't be any active mutation to target. Sometimes there will be active mutation, but there is no drug to target. Sometimes there is a drug to target, but we can't really get the drug. And even when we get the drug, and you can see it here, not necessarily that it will work. So we have some new tools to try to identify and to do individual the treatment for patients, but we are still not there in terms of benefit for the major of the patient. Most of the patients won't really benefit from this kind of approach. And there are a lot of reasons, I guess. One of them is the fact there is a heterogeneity between patients and between the tumors. And there is also an intratumor heterogeneity. Even when we have a patient with the same disease, in a different metastasis, there might be different tumors, different mutations. This is an example that a very famous study of Gerlinger in 2012, where we took different tissues from the same tumor, and he found out that actually every tissue that he took out have different DNA mutation panels, and that's the reason why he developed this phylogenetic tree. And the meaning is that, again, when we are addressing a biological treatment for a patient, it might work on part of the tissue, but not on all the tissue. And this is one of the reasons why we don't really able to cure these kind of patients. And another thing is another issue is the way that we think. So you can see in the upper demonstration the way we like to think, which is when we see a specific mutation, we think that if we will inhibit it, then it might kill the tumor. But the fact is that there are a lot of molecular networking inside the tissue, inside the tumors, and that's the reason why if we will inhibit one part of the net, it won't really influence all the cell and all the disease. And I will complete in the last slides talking about a little bit regarding how should we approach clinical trials in the precision, in the individualized era for cancer patients. And the idea is that you can't anymore take a whole cohort of hundreds of patients with a specific disease, because as I've shown you, every disease is different and every patient is different. And if we use targeted and more personalized treatment, we need to find new design of trials in order to prove that it really works. So there is a basket design in general, which is one gene in different histologies, and then try one drug only on patients that have this specific gene mutation. You can use an umbrella approach where you will take one disease and divide the same cohort with the same disease for different different arms based on their DNA alteration in the tissue. And you can do the octopus, which is both of them. And I will show you examples. For example, for a basket trial is this study that was published in New England several years ago, where they took different patients with diseases that are not melanoma, and they recruit only patients that had this mutation in BRAF, and they gave all the patients received the same treatment, and we found out that none of these diseases respond like melanoma. Most of the patients didn't respond. In the lung cancer cohort, there was around 40%, I think, and in general, we've seen only 42% in all the cohort of patients together, which is not what we was expecting based on the melanoma data. Another more updated example is Trk Fusions, which is a very rare mutation or a very rare alteration that exists in a lot of different diseases. And you can see here that it can be involved in adult cancers and then in pediatric cancers. And this is a study using a specific drug that inhibits this mechanism, and you can see that it's amazing success here. Most of the patients respond, and this is a very nice message for this small cohort of patients that have this kind of Trk fusion. But as you understand, we are not yet there in terms of the big population of cancer patients. Only very few of them. And this treatment was approved, and I will move on to the last part, which is an example of octopus trial design, the winter trial that was done also in Sheba and in another 3 major centers. And this trial was done actually by a consortium that we were part of it, a WIN consortium, where today there are around 28 centers of cancer centers that are part of this consortium, but also some biotech and pharma companies that are part of this consortium. And that's the reason why we were able to design a very different trial than what we are used to do. And the design were to take different patients with different histologies, with different cancer histologies. We biopsied the cancer, and we also took a biopsy from the normal tissue. We sent the DNA and the RNA for analysis. We got results from the DNA analysis and the RNA analysis, and then we needed to decide which treatment to give them based on all of this data. If it was based on DNA data, we addressed them to the arm A, and if it was based on the RNA data, we addressed them to arm B. Every week we were sitting in a video conference and speaking about the new cases and making a decision based on the data that came up. I'm finishing in 1 minute. And this is the statistical design. You can see here that the design, every patient is actually the control of itself. Every patient, we measured the PFS of the targeted treatment, and we compared it to the previous treatment, previous empirical treatment that he received, and the goal was to get the PFS2 versus PFS1 would be more than 1.5. It was pretty ambitious. You can see here the enrollment. We enrolled around a third of the patients, and eventually the studies have shown us that either if you are doing personalized treatment based on DNA mutation, or either if you will give the treatment based on RNA expression analysis, you will do 25% better than the previous standard treatment that you give the patient, which means that we are doing something right. But still, we would like to see a much better benefit for the patient based on these new approaches that we are speaking about. This is an example of one of our patients that entered the trial, and the lung cancer patient that received an inhibitor for the EGFR mutation T790M. This was before the third generation, the EGFR inhibitor that is approaching this mutation was approved. And in the conclusion, we realized that although we didn't reach our primary endpoint, eventually there is positive results either based on DNA mutation or RNA expression for the patients, and hopefully if we will improve our abilities to make a better decision based on the DNA and the RNA data, we might reach this reality that you see on that final slide, and I would like to thank you for it.